Okay, so we welcome everybody again yet to this another series of our Surgeonar. And the idea of Surgeonar, like always, is that you will be able to see the live surgery from the comfort of your own laptops and your own desktops in your own residences or in your own workplaces. And today in this series, we have a very accomplished surgeon who needs no introduction, and Dr. Jethwa from Jethwa Eye Hospital is going to be demonstrating 4 live surgeries in front of you. And I would now request Dr. Jethwa to start the live surgery program. I would be joined in very shortly. I think Dr. Rajesh Sinha is going to be joining in very shortly to moderate the session. And over to you, Dr. Jethwa.
Yes, good afternoon to all. Thank you, madam. Thanks to Dr. Rajesh giving me this opportunity to demonstrate surgery, and I'm glad that you also, you know, have given chance to a surgeon from a small town, and it's really pleasure. So I am from Anand, and Anand is a small city or small town in a Gujarat, and that is it's a mill city of India. It produces 24.3 million liters of milk per day. So today we are going to demonstrate 3 cases full, and last case a little bit if time permits. So just over to slides, please. Deepak, can you start? So this is the first patient. Can you make it full size? I can't. Yes. So he's a 62-year-old
Yes,
male,
yeah, we can see.
and we have planned for topical IOL under topical anesthesia, and we are going to use Technics Toric 2, which is a latest generation of toric IOL of the Johnson & Johnson. I have no financial interest. Second thing is our vision is a pure cortical 6/9 6/6 partial with pinhole. It's a cortical cataract, fundus is normal, and diabetes, blood pressures are controlled. There is no any other positive finding, and blood reports are normal. Next. This is a IL Master 700 chart. We would like to do each and every patient with a total keratometry, and we calculate almost all the patients with the Barrett formulas. Next. This is a Barrett toric calculator. You can see here that we have mentioned the incision at 180 degree, and there are 2 types of incision which I have written with the blue pen. There is 2.4 which gives a SIA of 0.2 diopter, and 2.8 incision which gives a 0.3 SIA. So you can put the incision at a different level, and you can increase or decrease the size, making sure you can see at the bottom that is ZCT 300, which gives a residual cylinder of 0.01 cylinder only. So you have to make a adjustment in such a way that our target should be as less as so far as the cylindrical part is concerned. This is a normal velocity and topo. There is nothing to say about it. And this is our final workout sheet or printout. We make it to all. You can show here. You can show this, which is hang over a microscope. So I'm turn karta. Yes, that's right. So you can see this. So this is a last moment printout we keep for each and every patient, which shows the different thing, which type of the IOL, what is the residual power, what is the endothelial count, what is the SED, and it is software connected, and there are multiple formulas and algorithms are there by which the software will say whether you use a trypan blue, whether you are going to use a mannitol or something for when the SED is less, whether you are going to use more viscose if the endothelial count is less, what is the position of the surgeon. Yes. So in this case we are going to make a temporal. You can focus. So we have made a special design of a, you can see the left eye and the right eye, we have made a circle like this, which is very helpful for putting the position of a surgeon. So my right hand will be at a 180-degree here, and we are going to start the surgery with the temporal approach. Give me the spectrum.
That's
So now over
that's
to
a
microscope.
unique and a wonderful thing.
I think we've not seen this before, and this
Yeah.
is truly a treat to watch. And I think it is something which everyone should also adopt. So really nice,
Yeah.
Dr. Jethwa, very nice.
Thank you, madam. Thank you. So I
Your
think
entire workup is just absolutely meticulous. I mean, right from the beginning.
so. Our workout will, guide you what to do and which precautions to be taken. So I now cornea पर वॉश ना बहुत ज़्यादा प्रेस नहीं करें या फिर इधर में चला जाएगा. I think now you can see. Can you trim it? So the center part of the microscope. Can you trim it?
I'm really sorry for joining a little late, but what I can figure out, is it a toric implant that we are doing now?
Yes. So there are. Can you show this again? There are two markings here. You can show this. Here, this. So you can see there's a 2-degree and 0-degree. So this marking has done as per my own toric marker axis marker F, and here the temporal side it is 2-degree, and nasal side it is 0. So from that we will put the desired axis. Yes, over to microscope. So when we go for the next patient, I will have a 6-minute video how this app is working.
I think it is again a great innovation and a great way of doing it.
So I put 2 incisions at a time. Okay.
You make both the incisions simultaneously?
I don't touch conjunctiva.
Okay.
It is not my. I've seen somewhere of the ones Israel surgeon was operating.
Okay.
And I got the idea from him. I forgot the name of that surgeon.
Yeah, but that's a very good thing. Because if you touch the conjunctiva, any hemorrhage is there, the whole advantage of doing topical phacoemulsification is gone, because the patient keeps complaining of redness.
Hydro, everybody got hydro. Is the microscope focused?
Yes, very well.
Just try to remove the air bubble. Light full. एकदम फुल ना ज्यादा.
एकदम फुल रखना. XY चालू.
ठीक है. A little bit nervous actually.
So you put Helon in the anterior chamber, or is it Visilon?
Yes. First, I forgot to tell. The first was a Helon.
Okay, and then now you are doing the Rexes from the side port.
I'm sorry, I'm a little bit nervous.
No, not at all. Not at all. I think.
Focus. So I followed the margin of a pupillary margin to make the round pupil. And if needed,
2.4.
It's again a new way and a very good way of keeping the maintaining a round rexis, that you are following the margin of the pupil.
Yes.
2.4.
The second thing, I put the main incision now, because otherwise what will happen during the rexis, interchamber will
2.4.
Yeah, it will become shallow, and I think that is why it was a perfect circle, because your main incision was not there, and this was being done from the side port.
this is a 2 degree, and I am putting an incision at 180, and this is 2.4 kiloton. This everyone knows the simple hydro, and I use the signature Phaco machine of Johnson and Johnson, and I use the dual pump. For few steps I use peristaltic, for few steps I use Venturi. So now it is almost hydrodissected. Yes. So best is to rotate with the two instruments, because there is no push and pull effect. A little bit you can reverse also.
Yeah.
The reversal helps in separation of a epinucleus.
Very nice.
Phaco 1, you can, expression range is 40, vacuum is 150, and power is 40. And it is a white star cold Phaco. Why I have kept peristaltic in Phaco 1? The reason is to cool the tip and make the tip cool all the time, because it requires maximum amount of Phaco emulsification. You can see, observe the tip of Phaco tip. You can see now it is seen. So
Yes.
direction of tip is changing when you are going a different part of the nucleus.
So you normally would make a trench in all the cases, or you are making it here because it is a grade 2 to 3 cataract?
Sometimes I chop the whole nucleus with two choppers if I see the golden ring.
Okay.
So I am going for a Phaco 2, trying to separate the nucleus.
350 vacuum, 45
Just let me know if the microscope is not focused.
No, it is perfectly all right. We can see its centration is also extremely good.
Thank you, madam. So I am trying to separate the central part of nucleus also. So now it is separated. Hold the one part. Very simple stop and chop.
350 vacuum, 45
You can take it, or if it is entangled, you can go for the second half to make the pieces, depending upon your conveniency and depth of entry chamber.
So what is the power of the intraocular lens that we are going to implant?
It is 21.5
Okay.
ZCT 300.
300 vacuum, 35 power.
You can see, as the cataract is not very hard, my OT sister has reduced the vacuum
Yes.
from 350 to 300. Now you can see that now only 2 or 3 are there,
275.
fragments. So she has reduced further,
Yeah.
275. So
I
it is
think
still
that-
last, a very small is there.
Yes.
So you can go for a 250 only.
So it does make sense to keep decreasing it, because your contents in your bag are decreased, and so there is more mobility, more space. So as you decrease,
200 vacuum.
it's
Secondly, we
really,
are operating in a 2.4 millimeter of incision.
yeah.
want to be a little bit restriction in inflow and more chances of
Nicholas?
surge. Smaller the incision, more chances.
Yeah.
So now it is epinucleus. Just hold it, catch it, then pull it, and after pulling, you absorb it like this.
Excellent, excellent.
So this is how you can pull in different direction so that the epinucleus is separated out. This step depends upon the depth of the AC. If AC is deep, you can do it. Otherwise, you can leave for cortex. I think I'll leave for a cortex removal. Irrigation is on, and as I learned from Dr. Vasavada that you must inject the visual on. It's थोड़ा छोटा है, small है, small. वही देता ना, चलेगा चलो. Because it is a 5 cc syringe, I cannot. I'm habituated with.
Continue on.
So you can see now I inject it,
Yes.
and then I remove the. It is not necessary all the time, but when the speculum is very tight, chamber is very shallow, patient has a posterior cataract, you are feeling that it was a hypermature white cataract and capsule is very thin, we can go for this thing.
I think it's a good thing to inculcate in your own habit that, once you're taking out the probe, it's better to inject viscoelastic from side port. So that will become a habit.
Yes.
It's a nice.
Second thing is between all the steps, my habit is to inject viscoelastic. So when I change from one step to another step, it is not without viscoelastic. So I remove the air bubble first, like this, and then we introduce it. So otherwise, bubble creates trouble. So as
Use bimanual.
Bombing is a fantastic thing,
Yeah.
which is invented in 1991, and Dr. Peter Lindberger of Switzerland, he is from Geneva University. He taught me that you forget all, you follow this. So from 91 we are using this. My first implant was in 1983 September. So we have a okay. You can see now there are some tags are there, which is beautifully controlled very well by good machine. We can remove it, all the tags, and make it polish. Vigiron. So Vigiron is on. Maybe
Continue off.
the micro movement of the posterior capsule up and down can transmit the waves to the macula, and that can also create a CME, postoperative, which was explained by Dr. Darjit Singh.
Yes, I think tremulous, any repeated tremulousness in the anterior chamber can create disturbances at the
Exactly, yes.
level
Yes,
of the vitreous also.
So over to the lens we are going to implant. This is a 3-cylinder 21 point diopter. I think you can see, and it is the difference between techniques 1 and techniques 2 is you can see the golden and rainbow shining of a material. I think you can appreciate it now. There are golden and rainbow. This is the polishing of a beautiful polishing of this lens. So just like folding our arms, we can fold the lens, push it gently as much as you can. And I put a viscoelastic and also a drop of moxifloxacillin over the viscoelastic. So now this is ready for implant. Even we can put it in a 2.2 incision also.
So you use a screw system or a push system, sir?
Push system should be discarded all over the world. I had very bad experience. It is not a good system. You cannot control. Here you can control in both the ways, forward and backward.
Yeah.
And I love the screw system. You can see now it's partly gone in a bag.
Yes.
And
Yeah.
next you don't touch, don't do anything. Just put a viscoelastic and put this folded loop inside the bag. Sometimes, the loops love each other so much that they don't separate.
Yeah. I think this happens with some of the lenses.
Yeah. So, but my sister always takes care. She first put the Isilon over the IOL both the surface, and then we fold it. So once the loops are coated with viscoelastic, then the chances are less. They stay stuck. If it's too much, then what I'll do is I'll not continue like this. I'll again inject, as I told you, again inject the Visalon, and then I do some maneuvering to separate the loop. It is better not to. Yes. So this is a safer way to
Yes.
use viscoelastic.
So there is a question which is being asked, and that is that are you following the precautions which you were following in the pre-pandemic era, or have we all shifted to a near normal level? So I think gradually all of us have shifted to the near normal levels. How about you, Dr. Jethwa? Do you follow some extra precautions for the possibility of COVID being there, or are we?
We go for two things: ask the history of common cold, any fever, and CRP.
Okay.
And any family who is suffering in, suffering in family COVID is there or not.
Okay.
Now you see, now we know that this marking is 2 degree,
Yeah.
and I'm going to put it at 2 degree exactly. Axis कर ली sir. So we are making it 0. So more or less 1 degree only difference is there. So from 2 degree we have marked 0 degree.
Okay.
I draw. You saw that there was some leakage from the main mold. So I do the partial hydro. And final hydro I will do later on. Why? The reason is, if I do complete hydro and by chance the cornea is also hydrated, then I can't see the axis. So it's a हाँ ये तो हाँ तो 0 मार्क कर दिया है.
175 IOLs.
So by irrigation, I remove most of the, without much aspiration, most of the visco, and as we all know, that is very important to wash the viscoelastic on the backside also, which I am trying to remove it. We put the marking with nullifying all the Purkinje's images more or less 0 degree. Wash time cornea bubble. You can see now
Yes.
it is at more or less 0 degree. This lens can move on either side. If it does not move, make the lens vertical and then rotate. It is easy to rotate, you know, like a coin.
Yeah.
Still, I am trying to make it at 0. Yes, now it is 0. Perfect. Hydro. You do the hydro.
Hmm.
I should thank the patient also who cooperated very well. By hydro, I take 2 hands, not a single handed. Hydro should be done with the 2 hands. Now the last and very important step for toric lens comes, and we observe that sometimes it gets rotated, and it's very common in this design of a lens. Light માં જુઓ તો low height કરો. And keeping the height little bit low, 65, 70. I see I'm just pressing the optic and touching the optic, little bit press over the capsule. So there is any fluid behind the IOL can be corrected. Rotation no. Still rotation is not as good as I want actually. It is, you can appreciate that it is not in a right position. Yes. Now we can see it's more or less okay. So you can take the support of specule or anything and inject moxie in the cornea, a little bit over the surface of cornea, and that's all.
Okay.
Nice.
Okay, thank you.
Thank you so much. That was an excellent demonstration, Dr. Jethwa.